Welcome to Grand Rounds. Today the sign-in will be recorded outside on the physical sheet outside of the conference room. Unfortunately, the electronic sign-in is not working this morning. I'd like to welcome Dr. Richard Bloomfeld as our Grand Rounds speaker today. Dr. Bloomfeld is a professor of medicine in the section of gastroenterology at Wake Forest Baptist Medical Center. After receiving his MD from WashU in St. Louis, Missouri, he completed his internal medicine residency and GI fellowship training at Duke. In 2000, Dr. Bloomfeld joined the faculty at Wake Forest to start and serve as the director of the Inflammatory Bowel Disease Program. Dr. Bloomfeld's research interests are in biologic development for treatment of IBD, recurrent C. diff infections utilizing fecal microbiota, transplantation, colorectal cancer screening, and GI bleeds using capsule endoscopy. His impressive research career is highlighted by his experience as PI on 33 funded projects and clinical trials, as well as co-authorship on numerous peer-reviewed papers and book chapters on IBD. He leads clinical trials nationwide to evaluate the safety and efficacy of biologic therapies for medical management of Crohn's disease and ulcerative colitis. Dr. Bloomfeld has served on the board of directors of the North Carolina Society of Gastroenterology since 2014 and is a member of the Crohn's and Colitis Foundation of America National Clinical Alliance. On behalf of the Department of Internal Medicine, please join me in welcoming Dr. Richard Bloomfeld.
Thank you, and thanks everyone for coming out this morning. Happy to be here to talk to you about Crohn's disease. I'm going to go through what's new in Crohn's disease. Here are my disclosures. And this isn't a comprehensive talk on Crohn's disease, but I'm going to try to bring us up to date on a few specific points. I'm going to talk about the importance of treating Crohn's disease early to get it well controlled. I'm going to talk about therapeutic drug monitoring. I'm going to introduce the idea of biosimilars. The anti-TNF biologics have been around for about 20 years, so most of you have grown up in the anti-TNF era, but I'm going to touch on the new non-anti-TNF biologics for Crohn's disease, and then talk about the changing paradigm of dysplasia in IBD. So this is a diagram of the natural history of Crohn's disease, and there's really two parts here. This lower line, which is the inflammatory activity of the disease, there's often some preclinical phase, and then you get increased inflammation, and it's often diagnosed during this time. Perhaps this patient's admitted to the hospital, make a diagnosis of Crohn's, perhaps you treat them with steroids, and that inflammatory activity gets better. And they may say they're feeling better, and we all say, hey, great. But in the background, Crohn's also has this ongoing tissue damage that continues. It results in the complication of Crohn's, like strictures and fistulae. And although the inflammatory activity may be up and down, and you may see patients and treat them with steroids at certain times, this tissue damage activity continues. Eventually, it often requires surgery for an obstruction or an abscess. And that doesn't stop it. It really just adds to the tissue damage when you've had surgery. And then it continues to go up. So in olden times, we used to say, let's try to use steroids, get people feeling a little better. And our goals are higher now, that we'd like to change this natural history of Crohn's disease by stopping this ongoing tissue damage. And that includes things like monitoring patients who feel better to see if their CRP is normalized, to see if their fecal calprotectin has returned to normal. And it also includes repeating colonoscopy to see if we have mucosal healing. And those all lead to better outcomes in stopping this ongoing tissue damage in an attempt to change the natural history of Crohn's disease. So as we get more effective therapies, we're not just about getting people over these inflammatory flares and having them say they feel better when they're perhaps in clinical remission, but controlling the disease process. And that's the importance of treating Crohn's early while you can do it and perhaps alter the disease course. This is a study called the SONIC study that was published in New England Journal of Medicine all the way back in 2010 that randomized patients with Crohn's disease who were naive to biologic therapy to azathioprine, infliximab, or combination with azathioprine plus infliximab. And this first panel here, we see steroid-free remission. In azathioprine, it was about 30%. Infliximab was 44%. And combination therapy was about 57%. So we found that infliximab was superior to azathioprine, and combination therapy was superior to either alone. The thing that's notable about this trial is these are really good remission rates in Crohn's. To see steroid-free remission rates of almost 60% is great in Crohn's. I'm going to show you some studies in a minute. You're not going to see numbers anything like that. And the reason is when you study a population of Crohn's disease that's naive to immunosuppression, they have short duration disease. In this study, the patients tended to have up to 3 years of Crohn's disease. And if you treat people early with effective therapy, you can see pretty impressive numbers for steroid-free remission and mucosal healing. And that's the kind of thing you need if you're going to change the natural history of Crohn's disease. So the lesson from this is don't put off treating, don't wait around, say, well, I'm going to wait till the next greatest treatment comes. To treat Crohn's effectively, we need to use the drugs we currently have available early in the disease course and use them effectively, not waiting for the next greatest treatment or waiting for a cure. We have to use the treatments we have early in the disease course. This is another study of an anti-TNF drug. This is certolizumab, and just another anti-TNF drug that did a study in Crohn's patients. And overall, this is response rates, not remission rates, but they found a response rate of about 63%, a placebo rate of 36%. So this anti-TNF drug works in Crohn's disease, and it was FDA approved. But in a post hoc analysis, when they looked at people who were enrolled in the study over how many years they had Crohn's disease, if you had over 5 years, your response rate was 57. 2 to 5 was up to 62. 1 to 2 years, 75%. And for patients with Crohn's disease of less than a year who were enrolled in this study, they had a dramatic 90% response rates. So early disease treatment gets you better responses rather than waiting for ongoing inflammation and tissue damage to occur. I'm not proposing that everybody from day one gets combination therapy in Crohn's disease, but we do have some markers of Crohn's prognosis. And patients who might do worse with Crohn's where you want to consider early aggressive therapy would include those diagnosed at an early age, ileal disease, especially severe endoscopic activity. You want to treat those patients more aggressively early. Those who have fistulizing disease, those who require steroids, and smokers all tend to have a more aggressive course. So think about more aggressive early therapy for those who have poor prognostic markers. In the future, I hope that we are better able to predict the course so that at diagnosis of Crohn's, we can predict somebody is going to have a more aggressive course, require surgery, fistulae, rather than one day they show up on the inpatient service and they got fistulae, abscess, say, wow, we sort of blew our chance to use aggressive medical therapy early, and now we really just need our surgeons to help rescue. All right, next I want to move over to therapeutic drug monitoring. Biologic therapy has been a tremendous advance in our treatment of Crohn's disease for the last 20 years, but biologic therapy is significantly limited by primary failure, where there's no response initially, and loss of response, where patients initially do well, lose response, and that's called secondary failure. It's clear to me we didn't learn how to best use biologics during the phase 3 trial of these drugs. What we saw is some companies picked weight-based dosing, IV, some picked fixed dosing, and with kind of limited preliminary data, they decided here's the way we're going to go. And we've learned that individuals really handle these drugs differently, have different pharmacodynamics, and the dosing that was chosen in phase 3 trials leads to all kind of different drug levels in people, and that perhaps if we can personalize the use of biologics, perhaps we can do better. So what therapeutic drug monitoring is measuring a drug level and an anti-drug antibody level in patients on therapy. And this comes in 2 flavors. We've got reactive therapeutic drug monitoring, which investigates loss of response. So somebody initially does well on a biologic, perhaps a year later, they're not doing well. Reactive therapeutic drug monitoring tries to explain why. Proactive therapeutic drug monitoring is an attempt to minimize loss of response. So this is really personalized medicine to adjust the dosing based on that person rather than waiting for loss of response. All right, so a quick case to understand reactive therapeutic drug monitoring. 32-year-old woman had abdominal pain, diarrhea, and was diagnosed with Crohn's ileitis in 2012. A colonoscopy showed active ileitis, and imaging showed an ileocolic fistula with narrowing, so there's already some signs of complications. So she was started on an anti-TNF drug, went to remission, and was clinically well for about 5 years on anti-TNF monotherapy. So we have a young patient already showing signs of complications, had early aggressive therapy, and did well. Patient now presents with recurrent symptoms. First thing we need to think about is why she has symptoms. Think about non-IBD causes. Is there an infection, C. diff, IBS? Non-adherence. When people are well for a number of years, they start wondering, do I really need this drug? Complications of Crohn's disease. Perhaps they're sick now because that stricture has progressed and there's obstruction. Or is this active Crohn's inflammation? So if active Crohn's inflammation is present, that would be loss of response. We need to think about why did they lose response to this drug? One possibility is immunogenicity. These anti-TNF drugs are antibodies. They are foreign antibodies, foreign proteins to you, and you can develop antibodies to the drug, and that would be immunogenicity. Altered pharmacodynamics. Perhaps the person is clearing this drug, and they just have lower levels. Or perhaps there's been a shift in the disease, and other inflammatory cytokines have become more important, and anti-TNF mechanism just isn't working. Well, reactive therapeutic drug monitoring would be where you have this loss of response and you measure trough drug level and anti-drug antibodies. And then your response in this patient who's losing response for Crohn's, you could increase dose of the current drug, you could change to a different anti-TNF drug, or you can switch to a new mechanism of action, such as anti-integrin or anti-IL-12/23 drugs, which I'll mention in a minute. So this 32-year-old woman with Crohn's disease who was well on anti-TNF therapy for 5 years and now has recurrent symptoms, had iron deficiency anemia, leukocytosis, stool studies were negative for infection, there was a high C-reactive protein, and an MR enterography showed active Crohn's ileitis with no abscess or obstruction. So this is active inflammatory disease, there's no complications or infection, this person has loss of response. So why? If we perform reactive therapeutic drug monitoring, we might get an infliximab trough level of 0 and anti-drug antibodies positive. So what would you do? This person has loss of response, no drug, and they have antibodies to the drug. Switch drug. Right, so they respond to that mechanism of anti-TNF, but we know this drug is not for them. They've got antibodies, they're clearing it. Let's go to another anti-TNF drug in the same class. So switch to that now. That would be a rational thing to do. If they have an infliximab trough level of 2 with no antibodies, what would you do? I will tell you that there's still some debate, but in general, you'd like an infliximab trough level of over 3, and levels over 7 have been associated with mucosal healing and healing of fistulae as well. But 3 would be a minimum. So if you have a low trough level of 2 and negative antibodies, you can raise the dose, increase. Perhaps they're clearing that drug faster now, and raising the dose of that drug before giving up on it is a rational thing to do. If they have an infliximab trough level of 9 and no antibodies, what would you do? If they have a good level of anti-TNF antibodies going through their bloodstream, they've got active disease, it's not working. Switch class of drug through a different mechanism. I mean, it kind of wouldn't make sense to, well, we're going to give you a different brand of anti-TNF antibody, so let's switch to a different mechanism. So reactive therapeutic drug monitoring provides a rational response to try to quickly get to what's most likely to work. I would say this is not based on good outcomes data, here's what you must do, but it provides a rational approach when you have to make a decision about what to do when this patient is flaring, and you have several options, and that's reactive therapeutic drug monitoring. So an algorithm, you've got a patient receiving anti-TNF maintenance therapy who relapses. You want to first confirm, yeah, this is IBD, and that's doing whatever you need to do, whether it's fecal calprotectin CRP, whether it's imaging, colonoscopy. If they have high drug levels, they're getting the drug, they're compliant with the drug, switch to a different class. If they have low drug levels in the presence of antibodies, switch to a different anti-TNF. Don't keep loading them up on a drug they have antibodies to. If they have low levels without antibodies, you might want to consider optimizing the dose of that drug before you move on to something next. So this provides a rational approach. Proactive therapeutic drug monitoring is personalized medicine. So rather than choosing what was chosen during these phase 3 trial of, here's the dosing that we kind of guessed on, you do therapeutic drug monitoring after induction and every 6 months during maintenance. So instead of If we know trough drug levels of 0 are associated with loss of response, or antibodies are associated with loss of response, why do we have to wait for them to flare and lose response to do something? Why don't we take a patient who's in remission on anti-TNF therapy and send therapeutic drug monitoring perhaps at 6-month intervals? If they have antibodies to the drug, they are likely to lose response eventually. Let's just switch them to a different anti-TNF drug before they lose response, which could result in steroid use, hospitalization, or even disease complications. If they have no antibodies to the drug, let's look at the levels. If they have a low level, or let's say a 0 drug level at trough, that is predictive of loss of response. Why do we have to wait? Let's increase the drug. If they have a high concentration, perhaps we could lower the dose. And I'll tell you in my clinic all the time, patients are concerned. They're doing well, and they're concerned about this immunosuppression. Can I cut back on the dose? Can I stop this drug? If we do proactive therapeutic drug monitoring, I might have a couple of patients I can say, yes, there's a rational approach. We can reduce your drug. Whereas somebody else who has therapeutic concentrations, we say, no, this is what success looks like. You're at a good drug level. It's working. We should continue this. So again, proactive therapeutic drug monitoring provides personalized medicine to try to minimize loss of response, which is a serious problem in our Crohn's patients. Outcome studies of proactive therapeutic drug monitoring in Crohn's disease are mixed. My interpretation would be that studies show patients who use proactive therapeutic drug monitoring versus usual standard of care end up staying on drug longer, but they haven't shown better outcomes yet. So what you're going to see is this is also a rational thing to do, but there's not good outcomes data. I think my pediatric GI colleagues do a lot more of this than I do. It's rational, but there's not good outcomes data yet, and it can be expensive to continually check drug levels and antibodies. So that's therapeutic drug monitoring. Next, I'm going to move over to biosimilars. So we're all familiar with generics, where patent protection expires, and a company will make a chemically identical drug, and the pharmacy can dispense it. We're all comfortable with generic drugs. These biologic drugs we're talking about are proteins, they're complex, they're antibodies. You can't produce an identical molecule. They've got the primary structure, which you can reproduce, but they've got secondary, tertiary, quaternary, post-translational modifications. You just can't make an identical structure. So the FDA had to create a new drug development pathway. And this is directly from the FDA. A biosimilar product is a biologic product that is approved based on showing that it's highly similar to an FDA-approved biologic product known as a reference product and has no clinically meaningful differences in terms of safety and effectiveness from the reference product. Only minor differences in clinically inactive components are allowable in biosimilar products. So the thing, if you trust the FDA, the thing to remember is that biosimilars have no clinically meaningful differences in terms of safety and efficacy, but they're not identical as a generic should be. So I'm sure everyone is familiar with the drug development process. So over here, we can see the typical drug development process. There's molecular characterization, non-clinical studies, and phase 1 clinical studies. And the clinicians probably don't look at that too much. If there's a new drug that you're going to bring to clinic, we usually don't look at those things. The phase 2 studies, which are the dose-ranging studies, and what you mostly look at is the phase 3 studies, right? The large efficacy trials where you look at the safety, you look at the efficacy, and as clinicians with a new drug, those are the big things that we're looking at. Well, the biosimilar pathway is a little bit different. Most of the work is going to be done in the chemical characterization and the functional characterization, where they check, binding of the drug. And that's where most of the work is, and where there's probably the best ability to detect if there's a difference. There are some non-clinical studies, and then pharmacokinetics and pharmacodynamics. If these drugs are highly similar, they should have similar pharmacokinetics and pharmacodynamics. And again, I think these are probably going to be more sensitive in picking, is there a difference, rather than clinical trials where you're going to expect the drug to behave similarly. So there will be some clinical trials to resolve differences, but if you're looking at a biosimilar, here's where most of the work's going to be done, and you should not expect a large phase 3 trial to be done for a biosimilar. We already know the drug works. This is to prove that it is not different. All right, so that's going to be the different pathway. There are two terms I want to introduce regarding biosimilars: extrapolation and interchangeability. Extrapolation is where a biosimilar is developed and does clinical trials in one indication that are successful, and then with that data and a rationale that there's the same mechanism of action in other disease, the FDA can approve the drug across all indications. So a biosimilar could be approved for use in IBD even if the limited clinical trials were done in rheumatoid arthritis. They can get extrapolation to all indications of the reference molecule with a rationale that the mechanism of action is the same. Interchangeability is another classification that's really above biosimilar, that you expect the same outcome if the reference molecule is given or if the biosimilar is given. So you can change back and forth and expect the same product. That is a higher bar than biosimilarity that I just talked about. When interchangeability is achieved, then there's the potential for drug substitution at the pharmacy level. Okay? So for the biosimilars, you must specifically prescribe, each biosimilar has a different name, you must specifically prescribe it and it can't be substituted. If a drug achieves interchangeability, then it can be substituted, although the laws vary state by state, and we'll see how this plays out. But many states have a law that a pharmacy can substitute it if they notify a physician, within 3 days. And that really may change our use of biosimilars if a drug achieves interchangeability. At this time, there's no interchangeable biosimilars, but we have 3 commercially available biosimilars to infliximab and 3 biosimilars to adalimumab that are approved but not yet commercially available. There's more coming. There's something called the Purple Book. So anyone who is interested in biosimilars, if you look up the Purple Book, that is a listing from the FDA about all biosimilars that are currently approved and for what indications, and that is constantly changing. All right, so there will be more biosimilars coming. Now, the thing about biosimilars, of why they're developed, is cost savings. Who saves that? Where does that money go? That's still playing out. So there are some countries that have gone to one of the biosimilar companies and said, okay, we're switching our country to this biosimilar, and that's the way they do it. Our country does not work like that, and it really remains to see how this plays out and who's going to save the money. Patients generally have very low out-of-pocket for this, so they're not saving the money. It's not out of my pocket. I presume that payers are the ones who are going to save the money. I can tell you that so far I have not had a lot of pressure from our insurers to switch to biosimilars. So there's kind of a lot of games going on about the use of biosimilars. The former head of the FDA was a proponent of biosimilars. I don't know how things are going to go with the new director of the FDA, but I think that will influence our use of biosimilars in this country. So it really remains to see how these biosimilars play out. But we should be aware, and they may well be coming when payers force us to. All right, next I'm going to move on to the new biologics. Again, I'm going to assume everyone is familiar with anti-TNF drugs. They've been around for 20 years. They really have revolutionized our treatment of IBD. And here are the non-anti-TNF drugs, which you may be familiar with in clinic or may see advertised on television. So vedolizumab is an anti-integrin drug. It's an alpha-4 beta-7 inhibitor. So that is an integrin that recruits white cells to your GI tract. So inhibiting alpha-4 beta-7 inhibits migration of white cells to the GI tract. That drug is approved in both Crohn's disease and ulcerative colitis. Ustekinumab is an anti-IL-12/23 antibody. So interleukin-12 and interleukin-23 are both inflammatory cytokines. They share a common P40 subunit. So ustekinumab is an antibody to that subunit, so it gets it inhibits both anti-IL-12 and 23. That drug has been approved in Crohn's disease, and there's encouraging data in ulcerative colitis. It will likely be approved in ulcerative colitis in coming years. Tofacitinib is a JAK inhibitor, Janus kinase inhibitor. It's a small oral molecule, but we generally group it in with our biologics. It has been approved in ulcerative colitis. It has promising data in Crohn's disease and will likely be approved in Crohn's disease in coming years. And these are the drugs that are currently available. For sake of time, I'm not going to go through the pipeline drugs this morning. Just to show a little data on these drugs, this first one is Ilysm, which is the anti-integrin drug. This is a study of Crohn's disease from the New England Journal of Medicine. Let's look at the top panel, which is clinical response and clinical remission. So this is after induction, 3 doses of drugs at 12 weeks. We see in Crohn's disease a clinical response rate of 14.5% and a placebo response rate of 6.8%. So that is statistically significant. This drug was approved for Crohn's disease based on this study. But wow, a remission rate of 14.5%. Not really that impressive. What you need to know about this study and Crohn's trials in this country is that these patients had about 10 years of disease. Most of them have already failed other therapies. It's a challenging group to treat, and we're going to have a lower response rate. This is what late treatment of Crohn's disease looks like. We see much lower remission rates. So the drug works. We use it. But these numbers are markedly different from other studies because patients who've never been on immunosuppression in this country have access to drug, usually, and don't like being in placebo-controlled trials. So this is what Crohn's trials often look like these days. It's not that impressive in terms of numbers, but the drug was superior to placebo and is approved. Ulcerative colitis, vedolizumab in my experience is a little more successful in ulcerative colitis than Crohn's, although the clinical trial numbers are still not impressive. If we go to this middle line here of clinical remission, vedolizumab had about 17% clinical remission rate. It's about 5.4% for placebo. Statistically significant, still not impressive numbers. I'm going to tell you higher numbers, respond. So if, the top line here, response rates of 47%, even if you don't achieve remission, a lot of these patients certainly feel better and might get clinically meaningful benefit, even if they don't achieve the definition of remission. So again, one of the newer drugs, it's successful. It's FDA approved for both Crohn's and ulcerative colitis. But this is why I say the treatment, the thing about Crohn's disease is it's not waiting for the, latest, greatest treatment. It's about using what we currently have available the best we can, okay? It's nice to know that these drugs are available. Ustekinumab, the IL-12/23 inhibitor that's improved in Crohn's disease. So the top panel here, we have clinical response. The bottom panel, we have clinical remission. So these are the 2 phase 3 studies, Unity 1 and Unity 2. You notice these bars are higher. What that means is that this study enrolled anti-TNF experienced patients, and this included mostly anti-TNF naive patients. So if you take patients who have not already failed other therapies, they're going to tend to do better. If you include everybody, including people who failed all the available therapies, they don't do as well. If we look at this study, which is a mostly anti-TNF naive population, we've got remission rates of 30 to 40% for drug, and this is 20% for placebo. So, acceptable, higher than if we look at the exposed population. And what this study did is they included a weight-based dosing and a fixed dosing, and the weight-based dosing was superior. So for this drug, ustekinumab, we do IV weight-based induction therapy followed by sub-Q maintenance. All right, tofacitinib, which is approved in ulcerative colitis only. This was published New England Journal of Medicine in 2017. We've got the induction studies over here and the maintenance study over here, and this top one is remission. So in the 2 phase 3 trials here, we've got 16 to 18% remission rates versus single digits for placebo. Again, drug is better than placebo, so it works. It's FDA approved. I will say that the response rates are higher, so more patients get benefit than just those are shown in the remission arms. But again, this study was done in patients with ulcerative colitis who've largely failed other therapies, and when used as a rescue therapy, these drugs have modest response. You can expect a lot better response if used earlier in the course. All right, and next I want to move on to dysplasia in IBD. So this is a changing paradigm. It is clear that dysplasia and cancer are increased in IBD patients with colitis. Ulcerative colitis is a diffuse colitis that involves much or all of the colon, and those patients clearly have an increased risk for colon cancer. Crohn's is a patchy disease that may involve the whole colon, limited colon, or no colon. For Crohn's patients who have extensive colonic involvement, they also have increased risk that's similar to ulcerative colitis. So if you've got somebody with ileitis, their average risk for colon cancer, just a few ulcers in the right colon, they're also about average risk. But when you start getting a third of your colon involved, then your risk becomes similar to ulcerative colitis patients, and we're going to group them in IBD patients with colitis. The old paradigm that you're still probably going to see on those who are taking or retaking boards is that screen everyone with IBD involved in the colon and take random biopsies. The idea is that dysplasia can be invisible, take random biopsies all over the place, and do a colectomy for anyone with dysplasia or a DALM. DALM is dysplasia-associated lesion or mass. So gastroenterologists sometimes get all bent out of shape saying, God, is that just a sporadic adenoma that anyone can have, or is that dysplasia from ulcerative colitis? When you call it a DALM, that means you want the surgeon to take the colon out. All right, so that's the old paradigm. Just take tons of biopsies, the dysplasia is invisible, and if you find dysplasia, remove the colon. All right, that was based largely on data from the 70s and 80s where we had fiber optic scopes and visualization just wasn't that great. And much dysplasia was invisible. Using newer technology, we've got high-definition scopes. We get great views. Dysplasia is mostly visible now, and that's why this is changing. So the new paradigm that will eventually make it to board exams, we have to screen the right patients. Not everyone is the same risk. So somebody with chronically active disease that involves the whole colon is at high risk. Anyone with PSC, who also has primary sclerosis and cholangitis, is at very high risk. You need to target those patients, get the colonoscopies done every 1 to 2 years. People with limited disease that's well controlled are at lower risk, and we should be able to individualize their screening regimens. And I find it punitive that guidelines currently say colonoscopy every 1 to 2 years in that group, and we're starting to come around. The new guidelines extend that to 3 years in the right patient. So we need to screen the right patients. We need to focus on mucosal abnormalities, not random biopsies. So using high-definition endoscopy, we can now see most dysplasia rather than it being invisible. So you want to look carefully, and when you see mucosal abnormalities that could be dysplasia, you want to biopsy those. It is clear that chromoendoscopy using dye improves your ability to detect dysplasia. So we spray methylene blue or indigo carmine on the wall of the colon and look carefully. That will allow us to see most dysplasia. So what is replacing those random biopsies is high-definition white light endoscopy with chromoendoscopy, where you look carefully, and instead of spending all your time passing biopsy forceps in and out of the scope, we look carefully. When you detect a lesion, you need to assess, is this endoscopically resectable or not? If you can see edges all the way around it, you can define that area. You remove that area endoscopically. If you can't detect edges, then it's not endoscopically resectable, and consider that patient for surgery. So we are eliminating the word DALM. We are now saying, after careful inspection, this is endoscopically resectable or not. And I'm going to tell you that most dysplasia is endoscopically resectable and doesn't require surgery. All right, so we are sending fewer patients to our surgeons for dysplasia because we have a better ability. Although we're detecting more dysplasia, we're sending a few patients for surgery because we have a better ability to detect endoscopically resectable dysplasia, resect it, and then again, now we've identified a patient who it's appropriate to do closer surveillance every year rather than somebody with well-controlled disease with a normal colon where we're punishing them with a colonoscopy every year because that's what guidelines say. So that's the changing paradigm. You will find different uptake of chromoendoscopy at different medical centers. I don't know when the board exams will change, that you don't have to take random biopsies everywhere, but this is clearly the way things are going in the IBD world. All right, so in conclusion, early treatment may improve the natural history of Crohn's disease. So in addition to just saying, hey, our patients feel better, we are monitoring them closer with CRP, fecal calprotectin, colonoscopy for mucosal healing. And if we get it healed, we expect to minimize the development of complications and surgeries. So early aggressive treatment with monitoring can improve the natural history. Therapeutic drug monitoring may optimize the use of our currently available therapies, and that's important. It's not about waiting for the next greatest drug that's going to, work in everybody. It's about using what we currently have available the best we can, and therapeutic drug monitoring is allowing us to do that. I want to say reactive therapeutic drug monitoring I find very useful, and I think we still need a little more data to show that proactive is the thing to do because of the costs associated with that. Biosimilars are emerging, and we'll see how that plays out in our clinic through external forces. New mechanism of action drugs are here. I showed you the data that they're better than placebo. We are just starting to see some trials that compare different biologics. Those studies are very expensive, and we're just starting to see a couple that compare the different drugs. I think it'll be important in the future to have predictors rather than saying, I'll call up, some expert and say, hey, which would you use? If we had a predictors in an individual patient, here's somebody likely to respond to infliximab. Here's somebody likely to respond to vedolizumab. That would be a big thing going forward, so we can choose the best drug for that patient, not the best drug from some speaker who said they thought that was the best drug. And we're going to see more mechanisms of action coming in the coming years. And the dysplasia in IBD paradigm is changing. Chromoendoscopy is currently here and is the most effective approach for screening your surveillance of your ulcerative colitis patients. All right, and with that, I will close and be happy to take questions.
Thank you, Dr. Bloomfeld. Please, as a reminder, please be sure to fill out your evaluations. At this time, I'll be taking some questions for Dr. Bloomfeld.
Rich, that was really great. I was wondering if you could talk a little bit about sort of the role of helminths in treatment of IBD and sort of the impact on the microbiome and what that tells us about, kind of the underlying mechanisms of disease.
Yeah, so there's been studies of worms to treat Crohn's disease. It's partly related to the theory is the underlying disease mechanism. We see that Crohn's is a disease of the developed nation with good sanitation, and we don't see it in underdeveloped nations with less sanitation, and that's the hypothesis theory. And there are some who came up with the idea of giving worms or Trichuris suis ova to Crohn's patients, and actually did better. So there are some studies showing benefits of giving worms to Crohn's patients. The FDA looked at it and said, this is not approvable and will never be approvable. Although these are not pathogens in humans, I don't think it's ever been described. I think the idea is, oh my God, what if we give this to a whole bunch of immunosuppressed patients? Maybe we can turn it into a pathogen in people. So it's not approved. I've got a couple patients who mail order these things from Germany, so they are available in Europe. But I think it's fascinating because there's got to be something on some antigen on those organisms that induces a favorable immune response. So I think that's at a phase where, yeah, we need our basic science people to learn what antigens are triggering the positive response and then converting that to a drug, and charging a lot more for it, will be something that might relate to the pathogenesis, and I think is certainly a positive marker for drug development, because that would presumably not be immunosuppressive, and patients will love having an effective non-immunosuppressing drug. You also mentioned the microbiome. Yeah, people with IBD have an altered microbiome compared to people who don't have IBD. At this point, I'd say we don't know if that's cause or effect. If you have an inflamed colon that's, bleeding and weeping fluid, it makes sense to me you're going to have a different microbiome. So we're not sure of cause and effect yet. But again, certainly a lot of interest in that. And again, there's several companies developing microbiome products to see if they can improve IBD as well.
Richard's wonderful. Based on some of our experience in cancer, I think the pressure for biosimilars may be coming your way in the near future. But I wanted to ask, when you do the therapeutic drug monitoring, you find someone has antibodies, but they're clinically stable. Have you gotten resistance from insurers to approve them to get the new drug?
So I have not, because I'm using mostly reactive therapeutic drug monitoring, where I'm looking at loss of response. I have not done a lot of proactive. So if so I don't check it often when patients are clinically well, but if I did, gosh, that is a strong rationale for changing drugs that I think I could get that through an insurance company, but without doing proactive, I've not come across a lot of that.
Richard, that was a really great talk. I have to say, Richard is like just the leader. He treats almost all our patients. For a long time, he did here at Wake Forest with IBD, and so he's really using these drugs and has this practical information. And it was just really nice to hear this talk. I was thinking about, treatments like for diabetes and cancer and some for kidney disease. When, not that you're as old as I am, but back when I was an intern and resident, all we had was prednisone for Crohn's disease. And people really did poorly, and they were in the hospital a lot. And I was wondering, with all these new drugs, which has been really a great thing, how has that affected the natural history of Crohn's disease for patients, and just epidemiologically, does it look like we're making great progress?
Let's call it slow progress. So I think in the early part of the biologics, so infliximab was first approved in 1997, I think. But back then it was single dose for active disease, and it wasn't until the early 2000s where it was approved for maintenance therapy. So that's where we're going to start seeing, potential changes through widespread use of these drugs. I agree, dramatic improvement over earlier decades where it was prednisone and sulfasalazine. So with these drugs being approved for maintenance in the mid-2000s, in earlier years, in 2010, there's all kinds of papers in general literature. Oh, we're not seeing any reduction in surgeries. We're not seeing reductions when we were 5 to 10 years in. Now we are. So now we're seeing studies with fewer surgeries for Crohn's disease. There was concern early in the biologic era. Oh, we're going to get these ulcerative colitis patients better. They're going to live with their colons. We're going to start seeing more dysplasia and cancers. The colectomy rate has gone down too. I think we're doing a better job of surveillance. So we are starting, 20 years into the biologic era, we are starting to see, I think, the benefits of the use of these drugs in terms of fewer surgeries for Crohn's disease and ulcerative colitis as well. But we still keep our surgeons very busy.
Absolutely fascinating, and I go back farther than anybody who's asked a question so far. But I do remember classmates, medical school classmates and so forth, who had this disease, ulcerative colitis, but at that time they were concerned about familial clustering and how that might alter your approach to the prevention of this disease. Any insights on that at this point? Or when you could stop monitoring people because that they're going to live out their lives and they don't have to be followed so often?
Yeah, so we're still not that smart about really all immune-mediated diseases. There's clearly a genetic predisposition to IBD. It seems to be a little more with Crohn's than ulcerative colitis. There's a study started by the Canadian Colitis Foundation where they took people with new diagnosis of IBD and took blood, DNA, and stool samples from all their siblings, so a high-risk population, and they're banking them and following them prospectively to find new cases of IBD in a high-risk population, which is, siblings, family members of IBD, to try to identify, is there a microbiome before diagnosis? And I think they're getting every year, is there a genetic predisposition so we can identify exactly what you're saying? So far, I think they're in the, I can't imagine hundreds or perhaps thousands of bank specimens. I think they have something like 10 new IBD diagnoses so far among family members and siblings. So there's nothing to draw conclusions yet, but you raise an interesting and important question that is being evaluated to see, can we identify who's at risk? Because that would be an ideal population to treat with a microbiome product or, something safe rather than waiting for them to get the diagnosis and then immunosuppressing them. If there's alterations in microbiome associated with those who get IBD, probiotics or whatever it takes for those people beforehand would be great. So there's a lot of samples out there, data being collected to try to answer that.
Thank you.
Any other questions? All right. Thank you, Dr. Bloomfeld.
Thank you.